Hi, this is Dr. Gardner, and I am giving you some major points on pharmacologic principles. So, what is the role of the advanced practice registered nurse as a prescriber? Of course, advanced knowledge, your assessment, your pathophysiology, this psychopharmacology, all of that is important when you're working in the role of as a prescriber. Your clinical judgment from assessment, your prescription writing. You must understand the disease process, which includes the pathophysiology. You need to know the pharmacology and the rationale. Why are you selecting a drug? If you're selecting an antibiotic, why are you choosing the one you need to choose? Well, that's things that you're going to learn in this course. So your clinical judgment in prescribing. So what is the indication for the drug? Which drugs are used for which disease? If your patient comes in with hyperlipidemia, are you going to write them a script for amoxicillin? Well, that one's common sense, right? Okay. But if your patient comes in with a bladder infection, what are you going to write? That's where you have to learn the classes of drugs and which drugs are used for which disease. What are your goals of therapy? Is it to cure? Is it to relieve? You have to know, what are you trying to do with the medication? What is the purpose of you writing that? And then your continued monitoring of drug therapy. So will it just be that you need to see the patient back to monitor their response? Do you need to get some lab work? So you have to understand which drugs require which kind of monitoring. And of course, the patient's medication history. You need to know any over-the-counter medications they take, because guess what? Some of those over-the-counter medications will interact with some of the medications that you're going to be prescribing. And the cost. If you prescribe a medication that costs too much and the patient can't afford it, their adherence will be poor because they're not going to take it. If they have to choose between a $500 drug and eating dinner, they're probably going to eat dinner. So what you consider is, okay, this is the medicine I want to give them, but maybe I can't. Let me look and see if there's another medication in this class that they can afford. Depending on where you work, it's always great to check the Walmart $4 list, because if you can prescribe something off the $4 list, your patient's probably going to take it. And of course, you also have to consider your sources of information when you're prescribing. So you may be asking questions to a poor historian. So can you prescribe based on that information? So how do we facilitate positive outcomes? How do we know if the patient is going to be compliant with the medications? What is intentional versus non-intentional adherence? Okay, so you saw Mrs. X today, you wrote her prescriptions, you gave her good education, and you sent her on her way. And she had every intention of taking her medication. But then she got home and she had no way to pick up her medication. And she lives out in the country where they don't deliver medication. So the next time you see Mrs. X, you're like, Mrs. X, I gave you this medicine and I gave it to you for this purpose. What happened? And she'll say, oh, shit, I couldn't take that. I didn't have a way to get it. So make sure you know your patient's history and if you're going to be able to do the medication that you want, and make sure your patient's going to be able to get the medication that you're prescribing. Also, if there's any adverse drug reactions, if they've had an adverse drug reaction to another medication, you're not going to prescribe that. And again, you need to know your classes of medications, so you need to get your patient's allergies. Um, any chronic conditions that may interact. So possibly your patient has heart failure and you're trying to prescribe um, an SSRI. Which one can you not prescribe? So you need to know these conditions and you need to know why you can give a medication and why you can't. So we went over all of those. Asymptomatic conditions, that one's a little bit more challenging because your patient isn't going to know, so they're not going to be able to tell you. So you're going to have a really good assessment and a really good history to facilitate a positive outcome. So, know and understand your patient, like Mrs. X, who may live way out in the country and have no way to get her medicine. Well, does she have anybody who helps her? So you find out. And if that caregiver comes, you collaborate with that caregiver on your patient's plan of care. Follow-up visits. So I'm giving you an antibiotic. Maybe you have a bladder infection. Do I want to recheck to see if the patient has cleared up? Do I have to? So it's good practice. Um, if I put a patient on a blood pressure medication and I send them out, oh, go forth and lower your blood pressure. When will I see them again? Should I see them again? Know your longer acting drugs and what they're used for. So you may have, say you're in the mental health program and you have a schizophrenic patient who's non-compliant, won't take medications by mouth. Well, this is a good indication to use one of those longer acting drugs. Simplifying the regimen. If you can give something twice a day instead of something 4 times a day, your patient is more likely to be compliant with that regimen. And understanding polypharmacy, because your patient is coming to you, but they also may be going to Dr. X and nurse practitioner Y and Dr. Z and getting a whole bunch of different medications. And they come and they've got this whole big bag of medications that they dump out. Okay, Shay, I need you to look at this. Well, is there some medicines that they maybe don't need? Are there medications that are interacting that maybe nobody sat down to look at because they don't know, they don't bring the medications? So know and understand if your patient has polypharmacy and what medications maybe do they not need to take, especially in our elderly population. Are there any sensory or mobility challenges? Can they open the bottles that they're given? So you have to really know your patient really well when you're prescribing and think really good before you do that. Is your patient going to be able to follow through with the medication? It's not just as easy as writing a script and please, here you go, you have your prescription, or sending it through eScript. Think before you write, or think before you send it on an eScript. Pediatric patients, they have different doses. So you have to calculate by their weight in kilograms. So you always have to get their weight. Their medications are different. And not only do they have doses based on weight, they have medications based on age. So that's something else you have to know. And we've already talked about our elderly patients. How do medications affect elderly patients? Well, it's usually a lot different. So that's something you need to be aware of. The age of your patient. Is your patient considered elderly? And what kind of modifications in the medications do I have to have? So I'll go over some of the principles of pharmacology, just the basics. So there is pharmacokinetics, which is the drug movement into, within, and out of the body. So how does the drug get to the site? That's pharmacokinetics. And then there's pharmacodynamics, which is drug actions and their mechanisms. I'll give you a few seconds to look over this little diagram. So if the response is you give a patient a medication and their response to that medication is below the curve, they're not going to respond to it. So they're not reaching a therapeutic level. However, if it's above the curve, then there's a possibility of toxicity. You've given too much. So those are the medications that you'll definitely have to use lab work and monitor labs. So the dose, the response curve is the relationship between the drug dose and the magnitude of the effect, which is again, do they have a response? Is it a responsive curve, or is it too much above the curve and it's toxic? So we'll talk about absorption, and that's the transfer of drugs from the site of administration to the systemic circulation. Most drugs are absorbed in the small intestines, and that's due to the large surface area. Distribution is the transfer of drugs from systemic circulation to the tissues. And then elimination. How are they removing that drug? How is it coming out of the body? So the liver and the kidneys are the main excreting organs. Drugs are mainly passed through stool or urine. So again, they're metabolized mainly by the liver, and they're excreted by the liver or the kidneys. So you have passive diffusion, which is a low molecular weight drugs, and those are both water and lipid soluble that dissolve in membrane and cross the other side. The primary means for which drugs cross membranes would be passive diffusion, which is the first means, or solubility, which is lipid and water soluble. The drug must be soluble in lipid and soluble in water. Filtration is the passage of molecules through pores of porous structures, as in the renal glomerulus. And transport mechanisms. That is, drug combines with a transport protein in the membrane, and the complex can move across a membrane. So remember, it's going to be proteins attaching to membranes. So your drugs are minimized by using other routes of administration. So after the oral administration, absorption is from the small intestines. Remember, it's from the small intestines because of that large surface area, and it goes into the hepatoportal circulation, which is pre-systemic. Oh, let me go back to that one. If I can go back. I don't think I can go back to that one. Okay, let's see. Okay, I wanted you to see this slide, so I had to start over. So it's minimized by using other routes, sublingual, sub-Q, IM, etc. So oral is the enteral administration route. Then you have sublingual, inhalation, and transdermal. Those all reduce the first pass effect. And transdermal patches have loading doses. So make sure your patient understands to rotate where they're putting that patch to avoid getting repeat loading doses in the same area. So that's going to be a part of your education. And then there's the topical route. So you have solids, which are tablets, capsules, caplets, the transdermal patch, or you may have liquids, or it could be a gas. You will not be writing any prescriptions for any gases or volatile liquids. So what is the bioavailability? How much of the drug actually makes it into the systemic circulation? So a fraction of an oral dose that appears in the systemic circulation could be reduced by that first pass effect. It may be because of altered changes in the gastro and the gut. It could be reduced because there's other substances present in the GI tract. So again, that's knowing and understanding what medications your patient is on, because an antacid will inhibit the absorption of tetracyclines. And there's so many more, but that's just one example. And distribution, which we talked about, that's movement from circulation to other body compartments. So protein-bound drugs cannot distribute to tissues or be eliminated. Therefore, bound drugs are pharmacologically inactive. One drug can displace another drug from binding. We just talked about that. Plasma protein binding. That prevents or reduces the amount of drug that's available for distribution. And plasma proteins are found in systemic circulation. So the blood-brain barrier, that is relatively impenetrable. It's protective, and it's only lipid-soluble drugs cross this barrier. The blood-brain barrier is a specialized barrier. The placental barrier, well, many drugs pass through that, and that has low molecular weight drugs pass much easier. Talk about elimination, which is go through biotransformation, and that's conversion of a drug to a different chemical structure. It mainly occurs in the liver, and that's through the CYP or the cytochrome P450 system, and that's a family of liver enzymes. So phase 1 reactions is your oxidation reduction reactions by oxygenases and reductases. That's your phase 1. Phase 1 reactions, oxidation and reduction reactions. Remember that. Phase 2 reactions is formation of conjugates by transferase, and then drugs are conjugated with a sugar, an amino acid, or a sulfate. So when we talk about the liver, it's secretion into the bile and small intestines is how drugs are eliminated. And there's an alteration of that intestinal flora can affect the action of some drugs. Drugs are eliminated mainly through the liver and the kidneys. So what could affect the renal excretion or drugs from leaving through the kidneys? Age, their kidney function, hydration. So maybe they're just dehydrated. They're not getting, and their cardiac output can also affect renal excretion of medication. So it could be the age of the patient, maybe they have poor kidney function, maybe they're poorly hydrated, or maybe their cardiac output is poor. So when we talk about mammary excretion, many drugs are excreted in breast milk. So you always want to check pregnancy categories, and I will go over that in a different lecture, but you want to check pregnancy categories when you're prescribing to mothers who are pregnant, because if they're breastfeeding, they could be passing that drug to the baby, and that has a smaller molecular weight. And it's lipid soluble, is also able to excrete from the mammary glands. Breast milk is acidic. Okay, so we talk about the first order elimination. So there's a constant percentage of drug eliminated per unit of time, or it's about 50% of the drug is eliminated about every 4 hours. So the plasma half-life is T times 1/2, which is the time necessary to reduce plasma levels by 1/2. A steady state is needed to achieve a steady state blood levels, and that's the amount taken in equals the amount you're eliminating. And it takes about 4 to 5 doses to reach a steady state concentration. Now, where do drugs initiate their effects? In receptors. So proteins that interact with a drug or a hormone to initiate a cellular response. Specialized protein that sits on the cell membrane. And so you'll need to know for sure, what is an agonist? Well, an agonist, it has the affinity and efficacy, so it is able to bind to a receptor. An agonist has affinity and efficacy. Efficacy is the ability to turn the receptor on. So it has to bind to the receptor and be able to turn that receptor on. So what is an antagonist? Well, an antagonist only has affinity. It has no efficacy, so it doesn't turn that receptor on. So an antagonist is not going to help. It won't start the medication. But by binding to a receptor, the antagonist can block other agonists from binding and turning the receptor on. So you really need to understand, what is an agonist, what is an antagonist, and know that for your medications as well. A full agonist can produce the full response. A partial agonist is only going to do, of course, it produces less than half, and an inverse produces a response than less than that of a full. It has an efficacy of 0. So we'll talk about rational drug selection, which we talked about a little bit at the beginning. So what's the process of drug prescribing, rational drug prescribing? Be able to define the patient's problem. What is your objective? Collaboration is usually important. So you may be collaborating with the cardiologist, you may be collaborating with the endocrinologist, you may be working in a different area and they may be collaborating with you. Choose the treatment, educate your patient, and then monitor for effectiveness. So you can't just prescribe the drug and then the patient's gone and we don't know what's happening after that. You're responsible for monitoring the effectiveness of the drug that's prescribed. Again, is your goal of treatment curative? Are you trying to relieve symptoms? Are you replacing deficiencies? Is there a long-term or short-term prevention? What is your goal when you're prescribing the medication or immunization? So treatment selection, we use evidence-based guidelines, and I added in Hippocrates for you, up to date, and we use peer-reviewed articles. Hippocrates has a free version. It's a free app, and that will be your best friend. One good thing, well, there's several good things about Hippocrates, but Hippocrates lets you know if something is off label. For if you're prescribing trazodone, and you will hear often about trazodone once you get into your clinicals because it's prescribed for sleep. But when you look at trazodone and you go to adult dosing, well, if you have Hippocrates and if you have the app, I want you to go to the adult dosing and notice the asterisk by insomnia. that lets you know that that medication is off label. So that is not FDA approved for insomnia. However, it's used widely. But if it is, if you prescribe it, you better have some good evidence-based guidelines to back you up as to why you're prescribing it. And not just because everyone does it, but know for yourself. Go and look at some peer-reviewed articles on trazodone so you can defend yourself when you're writing a script for trazodone. Up to date is very good. If through the Nichols library, you can use Up to Date for free. Take advantage of it while you're in school because they have great articles and great information. Okay, so I've gotten off that soapbox. Treatment selection is individualized for each patient. Now, you may have algorithms that you follow. Mental health, there's not a whole lot of algorithms. It's not really cookie cutter. But anytime you're prescribing a medication, you're going to individualize it to your patient. Consider the pharmacokinetics and the pharmacodynamics of the drug. Consider the cost. Now, when you first start prescribing, you're going to be analytical, step-by-step decision making. You're going to go to Hippocrates or you're going to go to Up to Date. You're going to look at those articles. Like you're going to go step by step. But as you get more experience, you start to have pattern recognition. So you start to have your own little arsenal of drugs that you use for hypertension because these are the ones you like. These are the ones you notice that work. So as you continue to treat hypertensive patients, you're not going to have to keep going to look that up because you already know that. So you're prescribing also based on experience. Now, I can prescribe a drug. Can you? Is there an indication for you to prescribe it? Do you know the contraindications for it? What are the precautions? Is it something that is it a precaution for pediatrics? Is it a precaution for pregnant women? Is there a precaution for the elderly? What's the cost? If it's too expensive and the patient's insurance does not cover it, if their copay is too high, the cost will affect their compliance. So know how much the medications cost. And the efficacy. Should I use this? Will this drug have an efficacy or is there an antagonistic effect of one of the other medications that they're taking? And what are the adverse effects? What should I be looking for to tell this patient to look for when you're teaching? Also, the dose, the duration, and the direction of the drug. These are all important to know if you're prescribing a drug. So you start your treatment. You educate your patient. Make sure you educate your patient, educate your patient, educate your patient. Write it down or document it in your chart because if you didn't do it, it wasn't done. Something happens to your patient and they come back and you didn't educate them, you can just write them a check. You might as well give them half of what's in your bank account and then some because they're going to get you that, well, I didn't know Dr. So and so or the nurse practitioner didn't tell me that. I didn't know that. And you go back to look at your chart. Oh, yes, I did. I told you about that. And you go back and you look and you kind of shortchanged your education. So you didn't put it down. Make sure that your patient has a full understanding and then also make a note in the chart about your patient having an understanding. And then monitor effectiveness. Is it going to be a passive where it's just patient education, remain in contact with the prescriber, or are you going to have some follow-up labs? Are you given something like cholesterol medicines? Okay. I have to reprogram myself, y'all, because I always think of mental health and I don't want to just give y'all mental health meds. But say you're giving them a statin. Do you need to follow them up with lab work? Something you'll learn and something you'll need to remember. And monitor for therapeutic effectiveness. So there are some drugs that you can give, and if they don't say some of the seizure medications, you have to check to make sure your patient is taking that medication. If they're not at a therapeutic level, they're not taking their medication. And if they're not taking, or maybe they're taking it and they haven't gotten to a therapeutic level, so you need to adjust your meds based on those labs. And of course, there's safety profiles. It varies by population. Um, Different drug allergies. Maybe they have liver or renal disease. Maybe there's tetragens, so you can't give medications because in uterine, it'll cause birth defects. So the profile of safety varies by the population. There's also the MedWatch report and Food and Drug Administration advisories. So some of the patient factors to consider, have they ever had any adverse drug reactions? What are their health beliefs? What is their current drug therapy, their age, and are they pregnant? So if you're giving medications to a woman of childbearing age, you might want to get a UPT, a urine pregnancy test. Alrighty, so that is it for lecture 1. And I hope to have lecture 2 coming to you very soon.